Dr. Stephen, please join us on stage. Dr. Mukesh, Dr. Sundarajan. Mukesh, please stay on stage. Dr. Bhupesh. Mukesh Mohan. Mukesh Mohan. Dr. Mukesh Mohan, please on stage. Nakili.
Good morning, sirs. And I really like this picture from yesterday, Muni's talks, standing on shoulders. Thanks to DVS sir for all the things they have done for us. And thanks to all the teachers, most of whom in the stage and downstage also. Thanks to all, sir. And the panel discussion is about this, learning from our seniors so that we do better procedures. Thank you, sir. So for all the juniors in the back, so this will be the main focus of the talk. So take a screenshot or take it in your mind. And I have also made a small in the lower right corner, so you can always look back if you have any doubt about what we are discussing. So in another 30 minutes, I plan to have 10 scenarios to discuss these topics. So without delay, going for the easiest first, the scenario 1, a 38 years male, an active individual, coming with pain in his left knee, affecting his daily life for 6 months. It is incidence onset. He does not know how it started. MRI showed a complex tear in medial meniscus, which is irreparable. So this is the alignment X-ray. And scanogram showed a mechanical axis deviation. There is a varus, and varus is localized to proximal tibia. So the points for discussion in this case, so I believe this is an ideal indication for a medial opening wedge high tibial osteotomy. Would any of the panelists like to differ, sir, or any other options in this case?
At first, how were the angles, the MPTA and the MLDFA in this case? I cannot see it.
Oh, it's not seen, sir? Okay.
For my eyes, a little bit too small.
Okay, fine. Okay, I'll tell the angles, sir. Mechanical axis deviation is 12 degrees. MPTA is 84 degrees. And mechanical distal femoral angle is 91 degrees, sir. And joint line incongruity is 3 degrees, JLCA.
So at first, you have more or less a deformity on both bones, at a femur and at a tibia, combined with an intra-articular deformity because of loss of meniscus and joint space of cartilage. And reconstruction of meniscus is not possible anymore. So I would go for digital planning, simulation of this case, and for double level osteotomy to adjust the alignment, because if you go just for one bone, you will end up with an oblique joint line, in my opinion, without seeing any simulation, but I would expect I would have an oblique joint line if I go just for an HDO.
Okay. So in Indian scenario, sir, how many would do a double level osteotomy, or how many do only opening wedge for this case? Lateral angle is 91 degrees, sir. 1.
Yeah, 91. If you would like to correct 12 degrees in a simulation, usually will end up in an MPTA more than 93. And if I go, for example, for 5 degrees correction at the femur, and then I have 2 small corrections, and then the joint line is after the procedure better. That's my personal opinion.
So we should consider double level osteotomy whenever the correction is more than 12 degrees. The point we taken. Thank you, sir. And for planning, the panelist, what do you personally do and what do you recommend for everyone? Is pen and paper sufficient or software always?
Software, no. Pen and paper is the best. Scale on the X-rays is also good enough, because if you don't have access to software, it is not that you cannot do it. So, and I follow the Miniachi method always.
Okay.
I think most of us use the software, because I think pen and paper is really good for an early learning. Definitely, it's a very good method to use it. But I think most of the softwares has got a very good predictability, and also you're going to do an intro again to make sure that it's correct. This gives only an idea how much correction you require, whether it's in the femur or the tibia, as already Stefan pointed out. When things goes more than 12 degrees, naturally you should go for a DF also. You have to see that anything which is more than 5 to 6 mm, more than the what you DFO is more than 87 for like 93 or 94, then I do a double osteotomy. It goes more than 12 degrees. Otherwise, most of the time, if you correct this is enough. Sometimes if you do a overcorrection in the femoral side and less on the tibial side, when there is no deformity in the femoral side, again joint line will be a problem. So that we have to aware of that.
The planning, the digital planning, I know the problem is sometimes the costs of the software, and so some colleagues avoid to buy the software. But in my opinion, even if it is expensive, you save so much of time if I compare to paid planning, and if you have a high caseload, I finish the analysis and the whole planning in definitively less than 10 minutes. And so everything is finished. And if I calculate all the time I save over 1 year, it's much better, and the simulation is a huge advantage. But I agree, paper planning is still possible, but time consuming.
Regarding the method, all panelists agree it's only the Miniachi method must be followed.
Miniachi method.
Yes, okay. Thank you, sir. So this is in a second scenario, a similar kind of images, but the patient is a 48 years male weighing 120 degrees and his BMI is 40.2. He's a shopkeeper, and again MRI shows an irreparable tear. We'll go for the angles. Mechanical proximal tibial angle is 83 and distal femoral angle is 91, sir. So the idea is, does this obesity preclude the option of H2O, or will panelists be okay with doing H2O in even this patient?
Can you go back to the previous slide to show the X-ray? Because still the joint is good.
Yes.
Joint is good, and this, of course, varus is a significant varus. How old is he?
48.
So
sir.
he is only 48. So we don't have much options. When the joint is good, is not much grade 4 arthritis. When you think about Mukesh has got no role here. So I would still prefer to do a osteotomy. Suppose if he's not, if he had tried all the conservative management like weight reduction, quadriceps exercises, and I tell them to avoid squatting, to do all those things, and I always tell them to come back after 3 months and 6 months, then make sure that he is asking for the surgery. Otherwise, if you don't try all the conservative directly, I don't do any osteotomies for any patients, whether it's obese or non-obese. So it's very important these patients have gone through all the conservative trial before they go for a osteotomy.
Okay. And any thresholds, sir, for our panelists to threshold of BMI or weight, so beyond which they will not advise H2O or any alignment surgery?
I'll be skeptical if she would have been a female at 48 with this kind of BMI. But a male, active, I may be still considering the surgery.
So that is the next case.
Conservative.
So next case is the
Weight reduction, offloading.
next one.
I guess the problem is always with obese patients, because we know independent of our treatment we have inferior results. The question is, should we avoid any treatment because we expect inferior results, or should we explain to the patient that they do not have to expect the same than a slim patient? And I personally have no limitation regarding body weight, but the risk of complication is higher. and the expected result is definitively inferior than the patients they are in the normal body weight. But I guess it's an individual discussion with the patient. But on the other hand, if you go for arthroplasty, the inferior results are the same, and the consequence in early changes of the arthroplasty is, in my opinion, higher. And if you can postpone the arthroplasty a few years with a knee preservation procedure, altogether it's an advantage of the patient, but it's an individual discussion.
So I think the point which you are bringing today for this case is that this patient doesn't have a grade 4 arthritis. So that is a different story. The same patient is a grade 3, okay, then grade 2 to grade 3, then a lot of discussions coming to whether to do a uni or a total knee replacement or an osteotomy. So a 45 years old female, male or female, doesn't matter, but it's a reasonably maintained joint. So you see that X-ray, standing X-ray, I believe, I think doesn't have much arthritis. So still, I would prefer to do a joint preservation surgery, osteotomy.
Would you like further X-rays like Rosenberg or Schuss view, sir? Do you routinely take them? Rosenberg view and Schuss view, more beyond the regular standing X-rays?
I don't do routinely.
No, I
don't.
Valgus or Avaris stress X-rays, sir? Do they? No.
Usually the weight-bearing X-ray shows the joint congruous angle. So you can always measure the joint congruous angle, and you can minus it when you have a deformity, more deformities. You have more varus, then you expect more JCOA. So naturally you have to calculate that also.
Moving on, sir, this 46 years lady, again, it's grade 3. I just want to go a little more controversial. Grade 3, BMI is 13.9. She's a work-at-home mother. I could have showed the face. She's in real pain. At 46, what can we offer for us? Since the alignment was not good, I wasn't able to do the scanogram measurements, because it was impossible to take a proper scanogram even for her. So what can we offer?
Which side is more symptomatic, right or left?
Left, sir. We are talking about left. Right, I think it is beyond our discussion. So left, we'll be talking about.
Why?
Right, it's almost grade 4, sir.
But sometimes that's why it sometimes will be deceiving. Sometimes when you have a severe varus deformity, you can have an overlap of your condyles.
Okay.
You may think it's a grade 4 arthritis. You take a stress X-ray, you correct the varus and take an X-ray, you will have a very good joint space.
Point taken, sir. Okay.
Yeah, so that point you have to consider always. Because this patient doesn't have any osteophyte, the right side. What I'm talking about, the right side.
Right side.
Still, I won't agree. It could be grade 4 arthritis. Still, just for the argument or a discussion point of view, that will be a good exercise. Always, you make sure that if there is no gross osteophytes to show that it's a typical grade 4 arthritis, if you have a doubt, always correct the varus and take one more X-ray. You see how much joints gets opened up. So in a grade 4 arthritis, when you do that, it is not open.
Okay.
So it's almost grade 4 on left side also. It's not grade 3.
Left side, I think it's grade 3,
That's what arthroplasty surgeons see.
Sir, actually, like what Sundar sir said, the right side I think is still forgiving. Clinical examination, how much of opening is there?
It was
valgus.
It was openings. It was not. It's not a fixed
in spite
varus.
of so much of varus and small-looking joint space, the shape of the condyle looks good in the right side, but the left side there is flattening of the medial femoral condyle. So that is something I am concerned about.
In this scenario of patients, I would prefer to take a Rosenberg view also to look into the posterior medial compartment. If I could demonstrate a bone-on-bone arthritis, at least in one view, then I would be convinced to do a replacement procedure rather than a preservation side.
I would like to know a little bit more about the complaints of the patient. How is the maximum walking distance of this lady?
She's severely disabled, sir. You can see it in the face. She's not able to walk even nearby or anything. She's restricted to her home.
So okay, the pain is a huge limitation for her daily activity, because that is for me very critical for knee preservation procedures, because if they are completely not active anymore, then the expected success is limited.
I think we should, before we decide anything, MRI is must if patient is having that much of pain to rule out insufficiency fractures or marrow edema, which usually leads to so much of pain, which can be managed very well conservatively before we jump into any kind of surgery.
Okay. So regarding open wedge height bill osteotomy, sir, any alignment surgery, can we say it's not to be considered in this patient?
To be left side, still I agree with Dr. Mohan, will be doing a uni in this patient.
This patient, okay.
See, for example, if the left knee is only a grade 2 OA and the right knee is in severe varus, would you treat the left knee first or the right knee first? Both are symptomatic.
Yeah, so the patient comes for the pain on the left knee. I would suggest
Both are symptomatic, but pain more on the left knee and severe varus on the right knee, and there is only grade 2 OA in the left knee. You want to do a H2O, right? So in that scenario, would you treat the right knee first by doing a replacement and then you go for H2O, or you do the H2O first and allow the right knee to load it?
So always I tell the patient that patient what for had come to the hospital. He had come for the left knee severe pain, not able to walk at all. But I tell the patient always that prognosis will be explained. So I say that always because of the grade 4 OA with the severe varus deformity, this is started deteriorating now. So we address first this, but you may require a knee replacement maybe after 6 months or 1 year. Once you have a pain, once this pain completely subsided, then if you develop pain on the right side, then you should go for a TKR.
Agree.
Okay. Another scenario, it's a grade 4 osteoarthritis in a young active male. He's in agricultural labor. He's again severely disabled due to the pain and also the abnormal gait. These are his X-rays, alignment X-rays. It shows 11 degrees of varus. Proximal tibial angle is 82 and distal femoral angle is 90 degrees. Grade 4 OA in a young and active male of 40 years of age. Treatment options, sir.
I'll prefer, being his laborer, I'll go for osteotomy in this case, though it's grade 4, but I'll go up to Fujisawa point, I'll offload it because of his demands.
Okay.
Yeah, I do agree with them because like since he's thin built and also very active and agricultural labor, I would like to preserve the knee.
So point to be taken, young active male, even grade 4, you should do an MRI, proceed towards joint preservation. Yes. Probably will overcorrect for valgus.
In this case, even MRI not needed. It's a grade 4 arthritis. It's well established in the X-ray. The only contraindication whenever you have a joint subluxations, then even in the younger age group, then the osteotomy will not do well. So if they don't have any subluxation of the joint, then you can prefer osteotomy still, but still explaining the prognosis that how long the osteotomy will last. That is the question from the patient. So when you say osteotomy, you say around 8 to 10 years is a normal lifespan when you have a grade 2 or 3 OA. So when you have a grade 4, definitely you cannot expect the same result. So you have to tell them that no, I cannot guarantee how long it is going to protect you. Whether 2 years or 5 years, you may end up in a knee replacement. So that prognosis can be explained and we can go ahead with the osteotomy in this case.
Thank you, sir. Moving on to the asymptomatic region. This is a 17 years old boy. He complains of some vague pain, but his main concern is cosmetics, sir. These are the angles. And I want to discuss two issues. Would anybody operate on this? And if at all you operate, I want to note this. This mechanical axis of tibia is outside the tibia. So is it for a case for middle opening with osteotomy or for deformity correction surgeons? I think there are two coras here, not in the proximal.
No, but the more significant is the tibia cora. So first correct the...
In tibia there are two coras, one in proximal tibia and one in distal tibia.
The central, the diaphyseal cora.
Okay.
So I think that has to be corrected first and then reassess this cora after correction of that and then take a call on what you have to do.
This looks to be a healed blocks, not only coronal plane deformity, there will be some rotational alignment also. So this has to be better referred to deformity correction center where they can do all these 3 plane corrections.
Okay.
I completely agree. It's in the proximal tibia. It's not an AP view. Also, the patella looks forward, so there should be a torsional malalignment there as well. And I'm very critical regarding cosmetic procedures in the alignment. I did in my whole career just one, and it was a very demanding patient in the aftercare. And I tried really to avoid it because we have not a good evidence to preserve the knee just because of a varus deformity. And so I would not do that. But so that is a personal opinion because I'm not a cosmetic surgeon.
So,
And it's not necessary. I mean, when they come for a cosmetic surgery, you can always explain. Of course, you have a deformity. You may end up in pain and later on. When the patient develops pain, then you correct the deformity. When they are asymptomatic, we should not correct. We should tell them that it's a cause. You have a problem. You are going to have a load more on the medial side. You're going to have some issues. Once they develop pain, then come back, then you do a surgery.
So ask them to catch the early symptoms and come before they go into more damage.
so no alignment surgeries in asymptomatic patients. So next we'll move on to varus knee or middle joint arthritic knee with associated lesions. Here is a 48 years old lady. She felt a dull ache about 6 weeks back and then a sudden snapping sound. Basically, all findings and clinical features suggestive of a middle meniscal root lesion, and MRI also showed a middle meniscal root lesion. These are her alignment X-ray. There is a 6 degree of axis deviation. It is symmetrical. Proximal tibial angle is 87 and distal femoral is 91. Sir. Now we have a varus, symmetrical varus knee with a meniscal root tear. Our options are whether to do meniscal root repair alone or root repair with high tibial osteotomy or just HTO to offload the knee and provide a symptom relief. Basically, when to add a high tibial osteotomy to a root repair in a symmetrical knee.
For me, it's the question, why should we go for an HTO? Because the angle is in the norm value with an MPTA of 87 and the deformity is at the distal femur of the distal femur is 91?
91, sir.
So distal femur is 91. So there is more the deformity at the distal femur. So I would go for the correction at the femur combined with a root fixation. My personal experience with root fixation in a varus deformity is inferior results and higher rate of failure.
I think we should see where the Mikulicz line is going. So if it's just say about 25% of the whole, just medial to the medial tibial slope, I'll not do anything. But if it's like going up to 50%, then I'll add the osteotomy.
Okay. So we went in for a root repair with HTO as a backup option, but intraoperatively we found a big cartilage lesion in the medial femoral condyle. But we did a high tibial osteotomy rather than distal femoral osteotomy because both sides it was around 3 degrees, so we did a high tibial osteotomy here. And hinge protection, yesterday Sundar sir told like he doesn't use it any longer, but I thought it's like good. I thought most of us are using it, so I'll just go with. Regarding bone graft, what is the threshold, sir? 8 mm opening, 10 mm,
12 mm.
12 mm opening. Okay, no bone graft till 12 for 12
No
mm.
bone graft.
Okay.
I do never use bone graft in a HTO, and regarding the hinge protection wire, I use it at the femur but not at the tibia.
Okay. So move on. And again, in this patient who had a symmetrical varus, correction to just neutral or beyond symmetrical varus, but there is a grade 4 cartilage lesion. So correction to be planned to just neutral or even beyond.
I think neutral will be better because other side also has got a varus deformity. I think neutral is enough because deformity is not a huge. So.
Okay, so even though it is grade 4, I corrected to varus. I just want to know the expert's opinion. Again, this has, I think we have discussed it. It's again a symmetrical varus, but Mikulicz line passes far medial. Even though arthroscopic features did not show any cartilage lesion, this patient needs a osteotomy. Do panelists agree so that we can move on?
My panel discussion also is over. You are showing the cases which I want to also show. It's okay.
Okay. So in severely varus knee, more than 10 degrees, even though it is symmetrical, So we'll be adding high table osteotomy also.
But always never to valgate the knees.
Okay.
Always neutral or undercorrect, never.
Are you okay with undercorrecting?
So she's been living with constitutional varus. So if you bring it to Fujisawa point, one leg in varus, one leg in valgus, they'll be very, very unhappy. So neutral, err on the underside, but not on the overside.
Especially in the female patient, we should be aware that the soft tissue at the knee is different to male. Usually, especially if they're a little bit obese, there's much more soft tissue in the medial part of the knee. And if you go for the overcorrection, then they start to have knocking knees immediately. So the overcorrection in this patient is really a problem for them later on. Also, the unloading is more, but they still have to walk after the procedure.
Okay. So this is another 46 years old lady, sir. I want to show the MRI also here. She again presented with a meniscal root tear and axis deviation of 6 degrees. MRI was reported mainly as only meniscal root tear. But intra-op we found this. Video is not playing? Ah, okay. Intra-op we found besides the meniscal root tear, there was a significant cartilage erosion in both medial and lateral compartments. We could not pick up in MRI, retrospectively, is it seen in MRI? These are just 1.5 Tesla MRIs for SERS. As usual, we had a plan was for root repair with a high table osteotomy set as a backup. But we had extensive cartilage lesion, medial and lateral. So what can we do for this patient? Age is 46 or 48? 46.
I agree, 46, but now she is primary OA with complete cartilage loss on medial and lateral side. So no conservative treatment or no preservation surgery will work. Just come out, counsel her, show them the videos and let them wait and buy the ticket.
Probably Mukesh is also very aggressive surgeon. So I do a still preservation surgery only. But I will explain the patient. Of course, you have to say that it's a grade 3. It's not a still grade 4. Still you have some layer is there. But I don't remove that layer. I don't do any remove the layer and do a microfracture. Leave the layer, do osteotomy. You just offload it to the joint. You wait and see. If it fails, then you do a lateral. Oh, lateral. Sorry.
Lateral also it is. So we just did the root repair and came out, sir.
And where are the pains in the knee? Medial or the lateral or in the whole?
Predominantly medial and acute onset pain. Everything was suggesting a medial meniscal root tear.
Then I agree and start with the knee preservation and explain to the patient if the pain is in the whole knee, then I guess it will be useless. Okay. But if it is just medial, then it could be for some years successful.
Yeah, the lateral side is grade 4 means then we cannot do osteotomy. So naturally give offloading braces, then wait and see, then later they can come for a replacement.
So we just did root repair and patient does not seem to be happy.
Okay. Lucky surgeon.
No, he's not happy. Not happy. Okay.
So Gitan.
First, we'll go on to the last case.
No, you want to show one more?
The last case or this case?
Okay, last one.
ACLs. I'll show one ACL and go for the last case.
No, one case. We'll finish with one case.
The last one you wanted to see?
Last.
Okay. Just wanted to see this one case alone. And this is a patient with neglected ACL insufficiency, presenting with predominantly middle joint pain. So far she's been having instability, but no middle joint pain is there. And MRI shows significant lateral compartment problems also. She's again just 37. So these are her angles. The deformity is mostly in distal femur, but lateral side is also involved, even arthroscopic also. Just have a quick discussion on this and go for the last case.
MRI showing cartilage lesions both on medial femoral and lateral femoral cord.
Yes,
Tibial
context.
cartilage doesn't show anything.
Medial
Lot
and
of
lateral,
marrow
and
edema in the
meniscus
tibia
also torn on both compartments. She has been having instability, she has been ignoring it, but now her pain starts, so she wants something to be done.
So I think Sundar will send it to Sundar.
And
Yes. So I think it's one of the rare case, and no, you're very young age, but ACL probably is a chronic ACL. He neglected it.
8 years
That,
old.
yeah,
ACL.
that resulting in both medial and lateral compartment. Okay, so both medial and lateral compartment. Unfortunately, we cannot offer much. There is no preservation surgery, osteotomies. So we have to tell them that you may end up in later on with the future
Some
replacements.
viscosupplementation to buy the time.
Okay, sir. So we'll move on to the last case now.
We have the senior most panelist here.
So this is Santosh's special request that it should be discussed because Sundar sir is here and simple case will bore him. So Santosh asked him to show this case.
It's from
So
one of
this
our
is-
colleagues.
So this is not my case. We'll not discuss what went wrong. We'll just discuss what should be done. It was a complex knee injury. Initially, it was a knee subluxation, sir. It was managed with lateral fixation alone, but progressively medial side collapsed and lateral side also opened. Surgeon went in for a second surgery, attempted an osteotomy, but again, there is no support on the medial side and that too has failed.
TCVO.
When a TCV was done, okay. So when he came to me, he had a fixed varus, knee stiffness also, and FFD also. He's again young male of 30 years male, active male, and he's lost his livelihood also, so he wants something to be done.
Do you can mention which ligaments are gone initially? Because it looks like a multi-ligament injury. The PCL is gone. The lateral and posterolateral ligament complex is not working anymore. And so I guess you have to go for revision of this complex definitively. But I do not know what is with the ACL. So I guess there we need a very good proper plan for because it's already revision, and it's very difficult to readjust the ligament stability in these knees. It's difficult primary, and in revision it's even more difficult in my experience. Totally. And so I would like to have the whole information of the first surgery, the whole initial injury, which ligaments were involved. And then we can think about the next steps, but it's very difficult to solve this knee.
So this is a typical case of combination of anteromedial depressed fractures, PCL insufficiency with lateral femoral collateral emulsion. We have a case series of around 6 cases now. So it was missed initially now. So the whatever you want to address, you should address it immediately. You should have reconstructed the bone and put a plate on the first situation, then corrected that posterior laxity. Then this patient might have been all right. As Stefan said, it's very late now because already revision surgery was done. And also I talked about anything with the joint subluxation. Okay, anything with the joint subluxation, it's a chronic joint subluxation. Not only in the lateral and the posterior subluxation, it's very, very difficult to reconstruct the tibial plateau and bring it and attach it. In my hand, I will not do again another surgery for this patient, preservation surgery.
But he is only 30.
Sorry?
He is only 30 years old.
That's why you are here.
No, but right now, I think we should deal with his stiffness first. His very stiff knee before we decide anything. The movements are only up to 30 degrees.
But I guess you cannot treat the stiffness without stability of the ligaments.
We need to, but I think after we get the movement, TCVO may play some role for a few years because then subluxations may get corrected.
See, one of the contraindication to do a TCOA is with the subluxations, joint subluxation.
So to
No,
make,
but
understood
the
that.
stiffness for this person is actually a protective mechanism because it is a very unstable joint otherwise. So at least he's able to walk now with some
so
pain.
he's walking with pain now.
Walking
So the
with
final
pain.
picture now, what to do for him? He has pain. So show the last X-ray, please. So he
He
has
can-
pain. So what to do now is the question from the surgeon. Patient has
The-
pain. He is not able to walk. He's 30 years. Shall I
See,
offer a joint replacement?
Other
or-
option is that, no, you can do an arthrolysis, we can get back some movements, we can protect with the medial unloading brace, so we can see how long he can go on with that. Later on, the pain comes back, then we have to do something.
He's already having pain.
What is with the medial meniscus? Is there still a part of the medial meniscus, or is it the medial meniscus completely gone?
What the surgeon told me was initially there was a PCL and ACL insufficiency, but now there is no sag because of stiffness. But he is complaining of pain. Initially there was a depression which was ignored initially, but he did a TCVO, but I guess without elevating the rim. TCVO was done ignoring the rim fracture. The rim is still down and the knee has fallen onto that rim currently and it's subluxed and fixed there.
I guess what you can do, but it is just a salvage procedure, because the rim of the medial compartment is gone, and you can replace it with a part of the iliac crest to put autologic bone graft there. But yeah, the success rate is not more than 50% in my hands.
So subluxation, anything to, I mean,
Yeah, I guess the problem is that the medial rim is gone for the subluxation. If you re-establish the bone with the bone graft, then I guess you treat automatically the subluxation.
he had repaired the lateral side. I think that's also ripped off and it's...
Both. There's a need for both.
So it will work after doing an arthrolysis, if you can able to correct the subluxations, then you can do a reconstruction medial tubular plateau with the PCL reconstruction that will stabilize the joint. We can explain the guarded prognosis and you can try that. But after getting back the movements of 90 degrees with the correcting the subluxations, if possible.
Thank you. Thank you very much, panelists. We're running late.
Thank you,
Thank
sir.
you, Geethan.
We'll close it.
Stephen, we are keeping you very busy. You need to stay on stage for the next talk. I invite Geethan to moderate the next session.